You're listening to the lecture on the management of patients with musculoskeletal disorders. By the end of this chapter, you should be able to describe the nursing management, rehabilitation, and health education needs of the patient with low back pain, discuss common musculoskeletal disorders of the hand, wrist, shoulder, and foot, as well as the nursing care of the patients undergoing surgery to correct these disorders, explain the pathogenesis, prevention, and management of osteoporosis, identify the causes and related management of patients with osteomalacia, Paget disease, and septic arthritis, apply the nursing process as a framework for care of patients with osteomyelitis, and recognize the causes and related management of a patient with a primary or metastatic bone tumor. Low back pain can be acute. It can also be chronic. It can involve nerve damage or nerve pain. Movement will usually make low back pain worse. You need to watch for signs and symptoms of serious complications when a patient does complain of low back pain, and those could be neurological deficits, which would show bowel or bladder incontinence because of damage to the spinal column, as well as cancer or infection within the spinal column. Whenever you're doing your assessment, your interview should include a detailed description of the discomfort, including the location, the severity, the duration, the characteristics. So what does the pain feel like? Is there any radiating of that pain? Any associated symptoms? Any leg weakness? Also, what were you doing when the pain occurred? So right before the pain started or even the day before, what did you do? Is there anything that you can think of that might have caused the pain? How have you been managing the pain? Have you been managing the pain? How has it affected your function and your independence? You want to ask them about their work and what they do for fun, because sometimes it might be chronic repetitive movements that is causing the damage, which then results in the pain. When you do a physical assessment, you're going to look at the posture of the patient. You're going to look at the curvature of their spine, and you're going to look for symmetry within the back and the limbs, as well as the hips and the shoulders. You're going to palpate the muscles that are immediately to the left and right of the spine to see if you notice any kind of swelling or nodules, pain to touch. The patient's ability to move, their ability to walk or ambulate, you're going to look at that as well. You can check deep tendon reflexes. You're going to ask them about their sensation, any changes in sensation, and then you're going to test their muscle strength, and you're going to do that bilaterally. Most times back pain is self-limiting and will resolve on its own as long as you have rest. You can take non-steroidal anti-inflammatories. You can take Tylenol or Motrin, some kind of non-prescription analgesic. Your patient might get a prescription for a muscle relaxant short term, and then they need to avoid any type of strain, heavy lifting, turning, twisting, because that can aggravate the low back pain. The patient can also wear lumbar support belts if they are going to be doing a lot of lifting or pushing or pulling. PT and OT can be prescribed to help with stretching exercises and to modify how they move and look at their body movement. They can do yoga and some kind of stretching exercises, strengthening exercises for back muscles. And they can also lose weight, because sometimes the back strain is because of the amount of weight that they have in and around their abdomen, if they have what they call the beer gut or the beer belly. Interventions as far as the nurse goes, you're going to educate and assist with pain management, both pharmacological and non-pharmacological. The patients can try heat and cold as well. You're going to look at how they're moving. Maybe they need to change their body mechanics. Maybe they need to change their posture when they're sitting or standing. If there's any work modifications, then they need to be educated on that. If they have any type of restrictions when they first go back to work, they need to be educated on what that means. When they sleep, they can sleep on their side with the pillows between their legs, and that helps to reduce the strain and the pull on the low back. And then if they can bring their knees up, it puts less strain on the back than if their legs were straight. When they stand, they should be standing straight. They should have their chest out, and then they should have their tummy up. So tilt the pelvis and then stick out the chest. When you're lifting, don't bend at the waist. They need to bend all the way down at the knees, and then keep whatever it is you're lifting, that object needs to be as close to the body as possible. As far as common conditions for the upper extremities, bursitis and tendinitis, that would be inflammation of the bursa is bursitis, and then inflammation of the tendons is tendinitis. The inflammation will cause proliferation of the synovial membrane and pannus formation, which will cause more restriction of the joint movement and can also increase the pain and swelling. Treatment is rest. They can do radiofrequency ablation if it's something that's chronic. Non-steroidal anti-inflammatories help a lot with the pain and the inflammation. They can also do stem cell therapies if it is something that's chronic and limiting their lifestyle. Laser phototherapy is also another option. Impingement syndrome involves lesions in and around the rotator cuff, causing impaired movement of the rotator cuff. Generally occurs from repetitive overhead movements. The patient will complain of pain, limited movement of that shoulder area. They can have muscle spasms. They can also have disuse atrophy because the pain is so limiting that they're just not using that shoulder. Treatment, they can get intra-articular injections of corticosteroids, non-steroidal anti-inflammatories. Cold and heat can help. Physical therapy can help with stretching and strengthening exercises as well. Carpal tunnel syndrome is manifested by numbness, pain, and paresthesia, as well as weakness along the median nerve, generally caused by repetitive movements, and the pain can be in the wrist going down the hand. Treatment, they can get the intra-articular injections of corticosteroids. They can get non-steroidal anti-inflammatories. Acupuncture can help. Wrist splints will help to immobilize the area until the inflammation can go down. They can try laser therapy, vitamin B6. If they have to, then they can get their surgery as well. A ganglion cyst is a collection of gelatinous material near the tendon sheath and the joints. It causes localized tenderness or pain because of the joint pushing on the area. Treatment, you can ask your physician assistant can aspirate the cyst to make it smaller. Corticosteroid injections can also help, and then they can actually surgically excise the cyst if it's causing too much pain or limiting movement too much. Okay. If you have a patient who's undergoing surgery of the hand or wrist, generally it is outpatient. It can be done at an outpatient surgery center. And you're going to focus on educating the patient about the surgery that is coming up, as well as what happens post-op and whenever they go home. They can use ice for the first 24 to 48 hours. They need to keep their extremity at heart level, and so if they're up and walking around, they can use a sling that will help with that. Neurovascular assessment is vital because you don't want to have any type of damage that's permanent. It's done in the first hour for the first 24 hours, and then it can be done every 1 to 4 hours after that. You're going to look at motor function. They should be able to do isometric exercises, and they need good pain control, especially initially after surgery. You need to instruct the patients on signs and symptoms of an infection, both local and systemic. You might need to teach them about wound care if they have a dressing that's covering their surgical site. If not, then they need to have instruction on surgical site care, keeping the wound clean and dry, and looking at the wound or looking at the incision to make sure that there's no swelling, there's no redness, there's no purulent drainage, there's no opening, so the incision is nice and has the edges well approximated. You want them to be as independent as possible. If their surgery was on their dominant hand, then it can cause further restrictions and loss of independence. So there's different modifications that you can teach them about, and then just make sure that they understand that their loss of independence is short term, ask for help when they need it, but they also need to be using their affected extremity as much as possible, while still following restrictions if they have restrictions. Common foot problems. Callus formation, that's a thickened area of the skin, and it's caused by persistent pressure or friction to that area. Generally is not painful. Treatment is to eliminate the underlying cause. So if it's friction or if it's pressure, try to eliminate that. Get better fitted shoes, shoes that fit properly so that you don't have the friction. And if they have to, then there's an ointment that will actually eat away at the thickened area and have it fall off so that the callus doesn't get too thick and too hard. If it gets too thick and too hard, it can crack, and then you can get an infection in the underlying tissue. They can have felt padding, orthotic devices. They can go see a podiatrist. The podiatrist can actually debride and remove that callus and shave it away as well. A corn is hyperkeratosis produced by internal or external pressure. It is generally hard at the center with inflammation surrounding the hardened area, so the surrounding tissue will be inflamed. It is painful and needs to be removed by a podiatrist. Ingrown toenails, that occurs whenever the free edge of the nail plate penetrates the surrounding skin. Because of the penetration, this can cause an infection. Treatment is prevention. So proper trimming of the nails, you need to trim the nails straight across. Don't go down and around, like don't do the U shape or the crescent shape, just go straight across with the nails. If you notice an ingrown nail starting to form, warm soaks can help, and a podiatrist can excise and remove that excess nail if they have to. Morton's neuroma is a swelling of the third lateral branch of the median plantar nerve that causes throbbing, burning, and pain in the foot. Treatment is rest. Sometimes massaging the area can help. Metatarsal pads help, and you can get local injections of a corticosteroid, which can also help reduce that inflammation and irritation of the nerve. If it gets bad enough, they can go in and surgically excise that neuroma. Flat foot is when the arch of the foot is diminished or completely flat. It leads to a burning sensation, fatigue. Sometimes it can lead to a clumsy gait, pain, and edema. Treatment is strengthening the muscles, so you'll have special foot exercises, and foot orthotics can also help. Plantar fasciitis is inflammation of the foot supporting fascia that causes acute heel pain experienced within the first steps in the morning, and then it usually gets better as the day goes on. Pain is localized to the anterior medial aspect of the heel. Treatment is stretching of the foot, stretching of the Achilles tendon. You can get supportive shoes, orthotic devices. They have these supportive socks that apply pressure in certain areas to help. And then corticosteroid injections are always an option. Sorry about that. They can do exercises. They can also do surgery to reshape and stabilize the foot if it is severe. If you have a patient who's undergoing foot surgery, you're going to do the same assessment that you would for any patient that is pre-op, following what we talked about in hand surgery. Go through their history, medical, surgical history, any medications they're taking, any concerns that they might have, any recent infections or treatments for a medical diagnosis. And then you're going to think about what they might need whenever they're discharged. So do they have stairs in the home? If so, how many steps? Do they have to go up and down the steps, or can they stay on the main floor? Because once you have foot surgery, you're generally not able to bear weight on that area. If they need a wheelchair or a walker, Do they have hallways that are big enough and doorways that are wide enough to fit the assistive devices through? Are they able to get on and off their bed, on and off of their couch, and on and off of the toilet, in and out of the shower? Those are things that you want to consider ideally before they have surgery so it can be all set up. Definitely post-op before they go home though. Uh, Most of the pain that patients experience post-op is related to inflammation. And so in order to control it, you should keep the foot elevated on several pillows to keep it level to the heart. Especially if they're sitting down, you don't want it dangling and completely dependent. They can do ice the first 24 to 48 hours, but no longer than 15 to 20 minutes at a time. They can also do analgesics, prescribed therapy if necessary, or prescribed medications if necessary, and then the non-prescriptions as well. They just need to make sure if they are taking something like a Norco or a Percocet that contains acetaminophen that they're not taking acetaminophen on top of that because they can take too much. They'll have regular dressing changes. They'll be instructed on how to do that if they don't have home care. And they need to look at their surgical site to make sure that they don't have any signs and symptoms of infection. You need to educate them on their weight-bearing restrictions because they will have weight-bearing restrictions, how to use the assistive devices, and make sure they actually show you that they know how to use them. And they need to keep their incision clean and dry, and the dressing should be clean, dry, and intact. Osteoporosis, there's two types. There's primary and secondary. Primary osteoporosis occurs in women after menopause, as well as men later on in life. It is not a typical consequence of aging. It just happens to show up in the older population. Early prevention and early maintenance of making sure you get enough calcium is the best way to keep your bones nice and healthy, and it will decrease the chance of osteoporosis later on in life. Secondary osteoporosis is a result of medication use like corticosteroids, also diseases, and alcohol use and abuse, smoking, because those affect the bone metabolism. Secondary osteoporosis is more common in men, whereas primary is more common in women. Risk factors for osteoporosis: small-framed women, the increasing age, so the older population, poor nutrition, especially if it's been ongoing throughout their life, bariatric surgery, of which the duodenum is bypassed, will increase their chances of osteoporosis because that's where the calcium is absorbed in the body, and you're bypassing that completely. GI disease that causes malabsorption, a sedentary lifestyle, and then a low BMI can also make you more at risk for osteoporosis. Osteoporosis can cause compression fractures, especially in the spine, and this will cause kyphosis in the curvature of the upper back, and that can affect the breathing. It can also affect your balance. It sets your balance off because your center of gravity is adjusted. Prevention of osteoporosis: make sure you have a diet rich in calcium and vitamin D because that will protect against skeletal demineralization. So foods that your patient should consider: skim milk with the vitamin D, cheese or other dairy products, steamed broccoli, canned salmon with the bone in, and calcium fortified orange juice. They should also do weight-bearing exercises. They should do 20 to 30 minutes of the exercise once a day. Aerobic exercises help as well. They can do calcium supplements. They just need to make sure that the calcium can actually be absorbed in the GI tract. There's also pharmacological therapy available. So in addition to the calcium and vitamin D supplements, they can get the calcitonin if the body isn't able to release enough of it, estrogen agonists to help with the effects of the hormone. Hyperparathyroid is another potential cause for low calcium, and so that can be given. As far as assessment goes, get a good health history, history of your present illness as well as family history, history of previous falls, history of previous fractures. Ask them about their diet in general and their calcium intake, and then see if you can ask them long-term calcium intake. Are they exercising? If so, what types of exercises? How often are they exercising? How long are they exercising? If they say they don't exercise at all, you can ask them if they go for walks, because sometimes people don't consider that exercise. If you have a female that is postmenopausal, you can ask them whenever their onset of menopause was. If they have hormone replacement therapy, if they drink a lot of caffeine, if they smoke or you drink alcohol, you need to know about that. Goals for patients with osteoporosis, they need to be well educated because you want to prevent any further injury or fractures. They need to know about the proper treatment regimens, especially if they're put on medications, when's the best time to take medications. If there's any restrictions with diet when they take the medications, like don't take it with milk, take it on an empty stomach, half an hour before you eat. It just kind of depends on what medicine they're taking. If they are taking calcium, they can get constipated. So they need to be educated on the fact that it can cause constipation. So they might need to increase fiber intake, increase fluid intake, and then talk to the doctor about stool softeners or mild laxatives. Interventions, if they have pain related to the osteoporosis, then especially if they're up for too long, the stress on the bones can cause pain. They can get a more supportive mattress. They can do frequent rest periods. They can get back rubs, light massage, nothing deep, but light massage. They can try heat or cold depending on what patients will say that one works and the other doesn't. So they can try either or. Heat generally helps more, but some patients will say that they like the cold. Osteomalacia is due to a lack of vitamin D. Because they have a lack of vitamin D, calcium absorption is inhibited. The calcium and the phosphorus in the extracellular fluid will remain low. So because it's low, it's not moving into the bone so that it can help with strengthening of the bone. And this leads to demineralization of the bone. There are several different causes. It can be renal insufficiency, metabolic acidosis, failed absorption, or excess calcium loss due to GI dysfunction. So there's actually something going on in the duodenum that's causing excess calcium to be lost, or it just isn't able to be absorbed. Malnutrition and then hyperparathyroidism are also causes. Patients will complain of pain, tenderness, and you can see deformities. You can see bowing of the legs. Sorry, I'm sure you hear my cat meowing. Her mom just went outside. So I guess not my cat, my daughter's cat. As far as treatment for osteomalacia, the primary defect in osteomalacia is the deficiency of activated vitamin D, and that is what promotes calcium absorption. So if you can resolve the underlying issue that's causing the deficiency or provide supplementation, then you can help treat the disease. Paget disease is the primary proliferation of the osteoclast will induce bone resorption, and this causes the osteoblastic activity to replace the bone, and this is a cycle. So the osteoclasts induce bone reabsorption, which makes the osteoblastic activity to replace the bone come, and it's not in an organized fashion, so you get very disorganized pattern of bone structure, and this will result in skeletal deformity over time. X-rays can show bowing of the tibia and the femur. It can also show just other small deformities that you might not see initially, but later on the deformities can get worse if it's not treated. Uh, the trunk can become flexed, the spine can bend forward, the thorax can become immobile, so you won't see the rise and fall and change in the thorax with respirations. Those are later stages that you'll see. And you can see changes in the tibia and fibula, or the tibia and the femur on the x-ray before you actually see it by looking at the patient as far as the bowing of the legs. Treatment, they can have assistive devices, and that will help take some of the pressure off of the bone so that they have less chance of it breaking. They can take NSAIDs for pain. They can be given shoe lifts and different orthotic devices to offset the pressure. Physical therapy can help. They can also take bisphosphonates. That helps to reduce bone turnover. And the ultimate goal is to relieve the pain and improve the mobility as much as possible. Osteomyelitis, there's 3 different classifications of osteomyelitis. There's hematogenous, which is bloodborne spread. So they have an infection in the blood and then it gets into the bone. Contiguous is contamination of the bone from surgery, an open fracture, or some sort of trauma. So it's actually contamination at the bone. And then there's osteomyelitis with vascular insufficiency. This is seen more in diabetes mellitus and peripheral vascular disease. Most commonly affects the feet, and the vascular insufficiency leads to necrosis, which then can lead to an infection. With osteomyelitis, the infection will cause the inflammatory response, initiating swelling, increased vascularity, as well as edema. After a couple of days, thrombosis of the local blood vessels will occur, which results in the ischemia of the bone. And because you have bone ischemia, you're going to have necrosis. The infection can move into the medullary cavity and under the periosteum, and then it can spread to surrounding joints and soft tissues if it's not caught and treated. As far as an assessment, you're going to assess for risk factors. You're going to assess for signs and symptoms of an infection. If a patient has a wound that's deep enough to be close to the bone, you need to be very much aware of the chance of osteomyelitis. So ask them about pain, bone pain, where is the pain? Is the pain better? Is it worse? Look at the drainage. And then if you can actually see the bone, you need to keep a really close eye on that bone to make sure that there's no signs of necrosis or vascular insufficiency, because that will lead to infection. If you do have a patient with osteomyelitis, then they are going to be on IV antibiotic therapy for quite a while. You will, as the nurse, need to help with pain control. Keep them as mobile as possible with the limitations and restrictions that the physician will put on them. So if they have osteomyelitis of the foot, then they won't be weight bearing on that foot, because that'll just take a lot longer to heal. It reduces the vascularity. If they do have a wound, then you'll be doing wound care as well as education to the patient. If there's peripheral vascular disease involved, you might be doing wrappings to the legs as well. As far as interventions, the client with osteomyelitis has bone that is weakened by the infective process. It needs to be protected so that you don't have stress on the bone. The stress on the bone can cause more damage to the bone, which can cause more infection, and it also makes it more difficult to treat the infection. So because of this, your patient's activity can be limited. Bed rest is generally not indicated, but you can have limited mobility of the affected extremities. So they do have to be aware of the non-weight bearing. Even if they're on non-weight bearing or limited weight bearing status, they still need to be up, because they generally won't just be put on bed rest. That can cause more complications. You want to try and maintain their ADLs as much as possible, keep them as independent as possible, with the understanding that they are going to need help. The most important thing is for them to heal and heal quickly. So if they're not following their weight-bearing restrictions, they're not following the orders of keeping their extremity elevated whenever they're sitting, that can prolong their infection and their treatment plan. And it can also lead to amputation if they really aren't able to heal and get rid of that infection. The pain can be severe. Immobilization of the affected limb can help with pain, but you still need to do range of motion on the joints above and below where the pain's at so that you don't get any type of contractures or deformities just from lack of movement. It's very difficult to treat a patient who has osteomyelitis because the bone is not that vascular. And because you don't have good vasculature, all of those nutrients and white blood cells that the body releases to help fight the infection just can't get there in the abundance that they could if it was some sort of soft tissue injury. That also means that the antibiotics that you're giving through the IV don't get there like they would if it was soft tissue infection. That means that your IV antibiotic therapy will last a lot longer. So patients can be on it for 3 to 6 weeks, sometimes longer. And then once the infection is under control, they'll be on long-term oral antibiotics. And that's to keep the infection at bay. If antibiotic therapy is not successful or if the infection is too severe, then they can have surgical interventions. And that can be anything from debridement with a bone graft to full amputation of the bone, and they'll usually take a little bit more, but the bone and the surrounding tissue if the infection is bad enough. Okay. Septic or infectious arthritis can be caused by a pathogen within the person, or it can be caused by some sort of trauma. So you can have infection somewhere else in the body that leads to the joint, or you can have an actual trauma to the joint that caused it. Generally seen in older adults, those who have rheumatoid arthritis, if they have skin infections, diabetes, then that also increases the risk for the infection. It's seen in knee and hip joints most often, and the patients will complain of the warm, painful, swollen joint, decreased range of motion, just like they would with any arthritic joint. But then they'll also have systemic signs and symptoms. So they'll have the fever, the chills. If they get a white blood cell count, then their leukocytes can be elevated, and their white blood cells can be elevated. So they just need to be treated. It needs to be identified as an arthritic infection and control pain, give them antibiotics. They might immobilize the joint because that will help with the pain. They might need to actually go in and remove the fluid, aspirate that extra fluid out, and that will help with the pain as well. Bone tumors, they can be benign or they can be malignant. The benign bone tumors is more common than malignant tumors, and the malignant ones can be seen more in children than adults. Malignant tumors can be primary, and that's whenever you have a tumor of the actual bone. So osteosarcoma is the most common malignant bone tumor, and it is generally fatal. If they can catch it early, they will attempt to amputate and follow up with radiation and chemo. You can also have soft tissue sarcomas that affect the bone and the joints. And prognosis is dependent on the type of cancer, where it started, how far it has progressed, if it's metastasized or not. If it is metastatic or secondary, this is more common than having a primary bone tumor that is malignant. And it can metastasize generally from the kidney, the prostate, the lung, the breast, ovary, or thyroid. Most of the time they're found in the skull, the spine, the pelvis, or the femur. And whenever they do have metastases to the bone, the treatment goes from being curative to being palliative. And then you just promote quality of life and then also do what you can to relieve the pain. As far as an assessment, just like you would assess anyone else, you have to have knowledge of the disease, you have to have knowledge of the treatment plan, you have to be realistic with what the prognosis is. so that you're not giving them false hope. So you need to assess the onset of symptoms, if it's a new diagnosis or if it's a recurrent diagnosis, if it's metastases or not. If it is metastases, a history of cancer, history of treatment. If they did go into remission and this is an exacerbation, then you need to get that information as well. You need to figure out how your patient is coping, what kind of coping strategies they're using, if they need any type of support, how is their family doing? Because the family will need support as well. If they are going to have surgery and have the tumor surgically removed, which can be done if the benign tumor is causing pain, then you would do just what you would do for anyone post-op. You're going to monitor vital signs, make sure they have a patent airway, adequate breathing. You're going to do neurovascular checks, make sure that they have good perfusion to the tissues and they don't have any nerve damage, and monitor the pain, assess for complications like infection or hypovolemic shock due to hemorrhage. You can monitor white blood cell count, make sure that there's no issues there because the white blood cells are made in bone marrow. And then also check their calcium levels. They need to have adequate calcium levels so that they can regenerate that bone. They can have delayed wound healing, especially if they have diabetes or if they have the onset of an infection, if they have poor nutrition. Make sure they're getting enough protein. And then make sure that they're not producing too much calcium. Goals as far as nurses are concerned with your patients, they should have adequate pain control. They should not have any kind of pathologic fractures because the tumor can cause stress on the bone. They need to make sure they have effective coping, and if they have any kind of deformities or if their gait is altered, their posture is altered, then that can cause a lower self-esteem, so that needs to be addressed. Make sure that you give them proper education and proper support, and make sure you listen if they need to talk. Okay. Patients who have had surgery because of a bone tumor, think about the patients with the orthopedic surgery or any other kind of surgery, really. You want to prevent any kind of further damage. You want to support the joint or the bone, the affected area. You might have to immobilize, apply ice if you have to, or if the patient wants it, you can do the intermittent icing. If they have restrictions, make sure they're aware of their restrictions and you monitor the fact that they are compliant with their restrictions, and then teach them how to use their assistive devices. Make sure that they're getting proper nutrition. Provide oral care, make sure that they're getting nutritional supplements if they're not wanting to eat. If the doctor will let the family bring in outside food, maybe that will help because they need to keep that protein intake up. If they are having problems with nausea and vomiting, they can get antiemetics. And the wound care needs to be aseptic technique to make sure that you don't introduce any bacteria into that incision site.